Okay, guys, sorry, there was some technical issue. I'm going to start again. Welcome to Unacademy, where you can crack all NEET PG exams with us, with our top educators, quality content, and have a great learning experience. A little about me. I'm Dr. Sasha Menon Remedies. I've done my MBBS from Father Muller Medical College, Mangalore, my MD in Anesthesia from Father Muller Medical College, Mangalore. I have 2 publications and 1 paper presentation in the field of anesthesia, and I've been working and teaching in Bangalore for the past 2.5 years. Field of anesthesia, and I've been working and teaching in Bangalore for the past. So, today's topic is monitoring depth of anesthesia, and a little about Unacademy. It's one of India's largest online learning platform where you can get plus subscription and access to unlimited live and recorded courses from India's best educators. Now, what will you get out of Unacademy? So basically at Unacademy, we have our so when you go to a coaching institute, you have to get up, get ready, you know, get there in time, etc. Then you have to get a proper place so that you can your educator can see you, you can see your educator. Your educator will have to have time enough to clear everyone's doubts. These are large classes, it's difficult, they are also time bound. Whereas at Unacademy, you can chat with your educator, engage in discussions, ask your doubts and answer polls, and all this is while the class is going on. Then all these courses are structured courses. So basically they are in line with your exam syllabus. So they are prepared in such a way that educators have researched, and your courses are prepared in such a way that whatever is needed for you all from NEET PG point of view, only that is what will be provided to you all, so that your functioning is optimum. Then we conduct live tests and quizzes. So we have our regular uh, we conduct regular tests and quizzes, which will it will actually help you all get a detailed analysis on your performance, and hence you all can function optimally, right? Then there is unlimited access. So one subscription gets you access to all our live and recorded courses, and you can watch from the comfort of any of your devices. So wherever you are, whatever you all might be doing, whether you are traveling or whatever it is, you all can watch from the comfort of your devices. Just a sec. So these are some of the top educators on our platform. Dr. Nikita Nanwani, she's a NEET PG mentor for radiology, as well as mnemonics and concept, focusing on must-know topics encompassing all subjects. Dr. Mohammad Azam, Dr. Devesh Mishra, Dr. Priti Sharma. And now Dr. Nikita Nanwani, she like I said, so mnemonics is a very interesting part. For those of you who mnemonics helps, it's really good because it really helps in remembering. But like for me personally, mnemonics never really made much of a difference, as I could not remember those short forms and all. I found it easier to relate and remember. But for those of you who for whom mnemonics works, this is brilliant, and making your own mnemonics is even better. So these are some of the courses offered on our platform. As you can see, there are different subjects that you all have to cover, almost 18 subjects, 19 subjects you all have to cover. I know it's not easy, NEET PG is not easy to crack. There are so many subjects out here and everything has to be done at once. Courses like psychiatry, radiology, anesthesia, dermatology, well, during MBBS you never really had to go into much detail. from NEET PG point of view too, you don't have to go into that much of detail, right? So these topics you don't have to go into that much of detail. These are a little more superficial topics. Superficial from the point of view that 11 marks are allotted each, and they will not go into detail with respect to these subjects. So the educators who for NEET PG, they will not go very much into detail, but you will have to read and go through the course structures, whatever is being prepared for you all and taught to you all, to be able to answer certain things in these exams. So they can ask you some stuff. So the general stuff is usually covered in depth for you all. And based on that, you all should be able, you all should go through material, give answer tests, quizzes, etc. And you all should be able to answer. These are some of the ongoing courses on our platform. Course on neurophysiology, GI surgery, cardiovascular thoracic surgery, uh, respiratory system, capsule on larynx. So these are some of the capsule on larynx, respiratory system, etc. Now, as you can see, the 5 types of subscriptions on your screen. Uh, so those of you who are so 6 months, as you can see, those of you who are giving the NEET PG this year, 6 months should be enough for you all, as you can see on the screen. Whereas the rest of you, like the 12 and 24 months, should be good. Um, So what happens with this 12 and 24 month subscription is basically it gives you time, right? So it gives you time to prepare, it gives you time to know what subject you might want, what subject you might not want. So it gives you a basis for that. Then also, like, your 12 and 24 month subscriptions are more economical. After 6 months, suppose you don't clear the exam, or if you don't want get the subject you want, you will have to subscribe again. Now again, that becomes an issue, right? Because you're spending that much money again. But with your 12 and 24 months, you of course have that buffer period. So as you can see, with 12 months, uh, use my code SASHA to get 10% discount, as you can see here. Then for this, you can avail the, so for the 24 month subscription too, you can use my code. Nobody, there is no harm in dropping 2 years. Nobody is going to ask you how long you took to clear NEET PG, why you took so long, blah blah, all that will not be asked. Again, you can avail a 10% discount. The discounts are applicable on all the types of subscription. So, monitoring the depth of anesthesia. What is the aim of monitoring the depth of anesthesia? Basically, to guarantee the safety of anesthesia as well as painlessness of surgery. So, the main thing is, the aim of monitoring is to guarantee safety as well as painlessness of the surgery. So, based on the monitoring, so when there is any pain During a surgical stimuli, there will be increase in heart rate, BP, and also while monitoring such such subtle variations can be seen, and it can be ensured that the plane of anesthesia is painless. And also overall incidence of intraoperative awareness is 0.2 to 3%. Incidence more than 40% in patients of cardiacs. So basically, the aims of monitoring is, one is to guarantee safety, painlessness of surgery, and the last point is prevent awareness. To prevent awareness. So the incidence is more than awareness incidence is more than 40% in patients with one cardiac surgery, two cesarean section, three multiple trauma, four hemodynamically unstable patients, right? So the risk is highest in these four type of patients, that is cardiac surgery patients, cesarean section patients, multiple trauma patients, hemodynamically unstable patients. So the risk of awareness is most among these patients. So historical background. Plomley first attempted to define depth by describing three stages, that is intoxication, excitement, and narcosis. Intoxication, excitement, and narcosis. John Snow described 5 degrees of narcotism. The first three included induction of anesthesia by ether, and last two represented surgical anesthesia, right? So 5 degrees of narcotism, first three was induction by ether, and last two surgical anesthesia. So Goodell gave the classic description of the clinical signs of ether anesthesia, which included four stages: analgesia, delirium, surgical anesthesia, and respiratory paralysis. So Goodell gave the classic description of the signs of ether anesthesia. So the signs of ether anesthesia, which were analgesia, delirium, surgical anesthesia, and respiratory paralysis. So Artosio expanded Goodell's stage 1 into 3 planes. So Goodell gave these 4 stages: so analgesia, delirium, surgical anesthesia, and respiratory paralysis, right? Now, stage 3, that is your surgical analgesia. Artosio expanded Goodell stage 1, that is your analgesia, into 3 planes. So, no amnesia and analgesia. So, no amnesia and analgesia, total amnesia and partial analgesia, complete analgesia, and amnesia. So Woodbridge defined 4 components of anesthesia: sensory blockade of afferent impulses, motor blockade of efferent impulses, reflex blockade of RS, CVS, and GI tract, and mental block or unconsciousness. Chris Roberts defined anesthesia as a state in which the patient neither perceives nor recalls noxious stimuli as a result of drug-induced unconsciousness. So the modern concept is that anesthesia is a complex interaction of multiple stimuli, diverse responses, and the drug-induced probability of non-responsiveness to the stimuli. Anesthesia can be defined by hypnotic, that is unconsciousness, and analgesic, that is pain relief components. So anesthesia can be defined by hypnotic and analgesic hypnotic, that is unconsciousness, and analgesic, pain relief components. The hypnotic component can be created by intravenous and inhaled anesthetics. The analgesic component can be created by opioids and local anesthetics. So the hypnotic is your inhaled and intravenous, basically the induction agents. The analgesic component is by your opioids and local anesthetics. So some drugs such as ether, nitrous oxide and ketamine provide both hypnotic and analgesic components to some degree. So certain drugs such as ether, nitrous oxide and ketamine provide both hypnotic and analgesic components to some degree. So these are the drugs: ether, nitrous oxide and ketamine. So these provide both the hypnotic as well as, they are both hypnotic as well as analgesic. So memory and anesthesia. Memory is affected much before notable autonomic responses are seen. So memory is affected quite early. The types of memory are short-term and long-term memory. Long-term memory can further be classified into explicit and implicit memory. Explicit memory is a conscious memory, refers to conscious recollection of previous experiences. So like recall test. So after GA asking the patient whether he heard any sounds or words during operation. So that is the conscious memory, the conscious recollection of previous experiences. Now the implicit is unconscious memory. It refers to the changes in performance or behavior produced by previous experiences but without any conscious recollection. So explicit is the conscious memory, that is a recall test can be performed. Implicit is the unconscious memory. It's any change in performance or behavior that is produced by previous experiences but without any conscious recollection. So long-term memory, a chemically mediated process involving NMDA receptors. So it is a chemically mediated process involving NMDA receptors. They potentiate the memory retention by mechanisms called long-term potentiation. So ketamine blocks NMDA receptors and antagonizes long-term potentiation, and hence there is low incidence of recall, right? So the long-term memory is mediated by NMDA receptors. They potentiate memory retention by mechanisms called long-term potentiation. So propofol impairs conversion of short-term memory to long-term memory, more potent than volatile anesthetics. Midazolam produces intense anterograde amnesia, and diazepam produces milder amnesia of both types. So anesthetic awareness, so it only occurs under general anesthesia. May recall some or all events during surgery, may or may not feel pain or pressure. So recall doesn't mean that the patient has to be feeling pain. The patient may recall some or all events during surgery but may or may not feel pain or pressure. So by definition, the state in which the patient has no conscious recall but under hypnosis can exhibit considerable and accurate recall of events. So it is a state in which the patient has no conscious recall but under hypnosis can exhibit considerable and accurate recall of all events. So the incidence of awareness during general surgery is with general surgery 0.11 to 0.16, cardiac surgery 0.3%, major trauma it is high 11% to 43%, and obstetric surgery it is 0.9%. So the major trauma has a highest incidence of recall of awareness, and followed by cardiac surgeries and general surgery. Lastly is your cesarean sections. So patient's perception of awareness, most common sounds and conversation. So the most common thing when the patient's perception of awareness is sounds and conversation. So 89 to 100% of the time the patient will be able to recall whatever conversation or sound that was heard. Sensation of paralysis also in 85% of the times. So sounds and conversation number about 89 to 100%, whereas the sedation and paralysis is only about 42%. Anxiety and panic, helplessness and powerlessness, pain in 39% of the patients. The least commons are visual disturbances, intubation or tube, and feeling the operation without pain. After effects of awareness there can be sleep disturbances. These patients might get up from the sleep very agitated and not knowing what to do. So there can be sleep disturbances, repetitive movements, nightmares, depression, flashbacks, panic attacks, preoccupation of death, post-traumatic stress disorder. Stages of awareness: conscious awareness with spontaneous unpromoted. So the stages of awareness are conscious awareness with the spontaneous or prompted recall, that is the explicit recall. Conscious awareness with amnesia, unconscious awareness with amnesia, that is the implicit, uh, and no evidence of awareness. Causes of awareness are light anesthesia, so nitrous oxide opioid relaxant anesthesia, myocardial depression, hypovolemia, cesarean section, difficult intubation. Premature discontinuation of anesthetic agents. So yeah, so like I was saying, the causes of awareness. I don't know. I'm sorry. I think it got stuck. There is some internet issue. Let me just check if it is back. Sorry. Yeah. So light anesthesia, nitrous oxide, opioid relaxant, myocardial depression, hypovolemia, cesarean section, difficult intubations. Premature discontinuation of anesthetic, machine malfunction or misuse of technique, increased anesthetic requirements. Now, prevention of awareness is by administering amnestic pre-medicants, whatever the amnestic pre-medicants, maintain vigilance regarding equipment and monitoring, minimize use of complete neuromuscular blockade, and maintain a point 0.8 to point MAC to 1 MAC. Should be administered to the patient despite adequate dose of. So how do you prevent this awarenesses? Basically, maintain the blood volume, supplement nitrous and opioid anesthesia, use multimodal anesthesia like potent volatile agent with analgesic as well as an hypnotic together, maintain a MAC of around 0.8 to 1 of volatile anesthetics, administer adequate dose of an induction agent, and obtain high risk consent for high risk patients, provide education and monitor for awareness. So components needed to define the depth after efferent stimulus. The components needed to define depth, efferent and efferent stimuli, right? So equilibrated concentrations of analgesic drugs, equilibrium concentration of hypnotic, so analgesic and hypnotic drugs, and equilibrium concentration of other relevant drugs like beta blockers, muscle relaxants, local anesthetics. So interaction surface relating to the drug concentration to the probability of the given response to a given stimulus. So stimuli are in approximately increasing order of noxiousness. Responses are approximately Responses are in approximately increasing order of difficulty of suppression as the cell progresses from left to right and from top to bottom. Increasingly large dose of anesthetic vapor are required when a given response to when a known response to. So as the cell progresses from left to right and from top to bottom, increasingly larger doses of anesthetic are required to suppress a given response to a stimuli, right? So as you can see, increasing anesthetic depth. So as the depth increases, large doses of anesthetic are required to suppress a given response to a given stimuli. Drugs and depth of anesthesia, inhalation agents, the purposeful movements of any part of the body in response to noxious perioperative stimuli is the most useful clinical sign of the depth of anesthesia, right? Erger and Merkel therefore define MAC as a minimum alveolar concentration of inhaled anesthetics required to prevent 50% of subjects from responding to painful stimuli with gross purposeful movements. So inhalation agents prevents purposeful movement of the body parts during anesthesia, during any episode. So MAC has been expanded as MAC awake, MAC intubation, and MAC bar. So MAC is basically the minimum alveolar concentration of the inhaled anesthetic required to prevent movement in 50% of the subjects, right? So MAC awake. Stolting has taken MAC awake as defined MAC awake as a minimum alveolar concentration that would allow opening of eyes on verbal command during emergence from anesthesia. MAC intubation is the minimum alveolar concentration that would inhibit minimum alveolar concentration that would inhibit movement and coughing during endotracheal intubation, and MAC bar is minimum alveolar concentration that could prevent the adrenergic response to skin incisions as well as venous pressure or catecholamine. So MAC bar again, minimum alveolar concentration that would prevent adrenergic response to skin incision as measured by venous concentration of catecholamine. So you have your MAC awake, MAC bar, and your Now, induction, that was your inhalation agents. Induction agents, that is non-opioid and IV induction agents. Plasma drug concentration peaks in half to 1 minute and declines rapidly due to redistribution of these IV induction agents. The depth of anesthesia follows plasma drug concentrations, right? So clinical endpoints for assessment are loss of verbal responsiveness, loss of eyelid reflex, loss of corneal reflex, and strongest stimulation during induction is laryngoscopy and intubation. So analgesics are needed to maintain hemodynamics. So the depth of anesthesia follows plasma drug concentration. So endpoints to know that when a surgical stimulus, so when laryngoscopy is done, the endpoints to know that the patient has been induced well is there is no verbal response, there is no eyelid reflex, there is no corneal reflex. So, maintenance of anesthesia. So, plasma levels of anesthetic agents are accurate predictors of brain levels of the drug and good indicators of anesthetic depth. So, plasma levels are good indicators of brain levels as well as anesthetic depths. Yeah, so like I said, even for maintenance, plasma levels of anesthetic agents are accurate predictors of brain levels of the drug and good indicators of anesthetic depth. Again, endpoints are loss of eyelid, corneal, loss of eyelid reflex, corneal reflex, and absence of movement in response to squeezing trapezius. Opioids in large doses need to be added when precise hemodynamic control is necessary, as in coronary artery disease. Opioids. Now the CP50 is steady state concentration of opioids, which will prevent purposeful movement to noxious stimuli in 50% of the patients. So clinical events which indicate inadequate infusion rates are increase in systolic blood pressure, more than 15 millimeter of mercury above normal for the patient, somatic movement, shallow, um, heart rate more than 90 in the absence. Heart rate more than 90 in the absence of hypovolemia, increase in systolic BP more than 15 millimeter above the normal. Um, so basically tachycardia, hypertension, somatic movement like swallowing, coughing, lacrimation, sweating. So all these indicate a lighter inadequate infusion rates and lighter planes of anesthesia. So assessment of depth. So depth assessment can be done by, it can be subjective methods like cardiorespiratory, that is the rate and depth of respiration, blood pressure, heart rate. Autonomic, that can be lacrimation, diaphoresis, mydriasis. Somatic can be skeletal muscle movement. Objective methods are lower esophageal contractility, facial electromyography, EG monitoring, EG derived monitors, uh, include past spectral analysis, bispectral analysis, narco trend, patient state analysis, and evoke potential. We will deal with each one of them. But now, autonomic changes include sudden hypertension, tachycardia, sweating, tearing, commonly used as a clinical indicator of lightening of depth of anesthesia. The patient response to surgical stimulus scores include four: hemodynamic parameters such as blood pressure, heart rate, sweating, tearing. So the PRST score is of 4, that is the patient response to surgical stimuli. That score is 4. The PRST score, as you can see, so the PRST is nothing but the patient response to surgical stimulus. So it is patient response to surgical stimulus. So So pressure less than 15, control plus 15, control plus 30, more than control plus 30. So 0, 1, 2. Less the pulse rate less than control plus 15, less than control plus 30, more than control plus 30. 0, 1, 2. Sweating, no sweating. Skin is moist and visible beads of sweat, again 0, 1, 2. Tears, no excessive tears in open eyes, excessive tear in open eyes, and tears overflowing, 0, 1, 2. So this is the patient response to a noxious surgical stimulation. Score includes 4 hemodynamic parameters that we just did: the blood pressure, the heart rate, the sweating, and the tearing up. These should not be mentioned. I mean, these are the patient's response to surgical stimulus. However, this need not always indicate lighter plane of anesthesia or awareness, because these changes are also seen with intraoperative events like hypotension, dehydration, hypoxia, hypothermia, or sudden blood loss. So drugs like beta blockers, inotropes, vasodilators, antihypertensives also lead to hemodynamic response to noxious stimuli, but not necessarily signify awareness, nor does lack of hemodynamic testimony change guarantee and unconsciousness. So this hypothermia, hypoxia, dehydration, hypotension, use of inotropes, drugs like beta blockers, vasodilators, antihypertensives also lead to such hemodynamic alterations. Now, pupil diameter, the change is pretty unreliable. So the change is unreliable. Dilatation is affected by catecholamines, atropine, opiates, and pupillary reflex is affected by opioids and anoxia. Isolated forearm technique. Isolation of arm from IV muscle relaxants. Tourniquet is applied on an arm and inflated before giving muscle relaxants. Arm is unparalyzed. Patient will respond to commands if depth not adequate and ischemia is a problem. So the objective methods are the lower esophageal contractility. So the non-striative muscles in the lower half of the esophagus retain their activity even after full skeletal muscle paralysis. So non-striated muscles in esophagus, replace the striated muscles in the esophagus. So the non-striated muscles, lower half of esophagus, retain their potential activity even after full skeletal muscle paralysis. Spontaneous and provoked lower esophageal contractions reduce in latency and amplitude during GA, measured using a balloon in stethoscope. Published evidence is limited. So that is why he fell. That is why the lower esophageal, the non-striated muscles, they retain some activity, right? So they do not get paralyzed completely. Spontaneous and provoked lower esophageal contractions reduce in latency and amplitude during general anesthesia. And this lower esophageal contractility can be measured by using a balloon in the esophagus. Facial electromyography. Facial expressions reveal stress. They can be abolished by anxiolytic drugs, sedatives, and general anesthesia. Spontaneous electromyography of frontalis muscle is used to monitor activity of this muscle under anesthesia. So this EMG electromyography can be abolished by anxiolytic drugs, sedative, general anesthetics. A monitor which displays the frontalis muscle far as a trend has been used in anesthesia. It detects very light anesthesia, nothing of great clinical significance. So electroencephalogram. EEG is a surface recording of the summation of excitatory and inhibitory postsynaptic potential spontaneously generated by the pyramidal cells in the cerebral cortex. So four perioperative uses of EEG. So there are four perioperative uses of EEG. One is identify inadequate blood flow to the cerebral cortex caused by either a surgically induced or anesthesia induced reduction in blood flow or retraction on cerebral tissue. To guide an anesthetic induced reduction of cerebral metabolism either in the anticipation of loss of cerebral blood flow in the treatment of high intracranial pressure. To predict neurological outcome after a brain insult and gauge the depth of hemodynamic so to gauge the depth of the hypnotic state of the patient. So basically this EEG is used to gauge the hypnotic strength, predict the amount of neurological impact to the brain. Brain would be basically it indicates any abnormal EEG will indicate abnormal cerebral blood flow. EEG is low voltage. EEG is a low voltage 5 to 100 microgram deflection recorded from the surface of scalp. Cerebral physiology and metabolism both affect the EEG, and anesthetic drugs affect both cerebral physiology and EEG. So cerebral physiology and metabolism both affect the EEG, and anesthetic drugs affect both cerebral physiology as well as EEG. Different conditions result in different frequencies and amplitudes in the EEG waves. So waves are designated as alpha waves 18 to 13 waves per second, beta more than 13 to 60, delta 1 to 5, and theta is 4 to 8, right? So basically your EEG surface recording of the summation of excitatory and inhibitory postsynaptic potentials generated by the pyramidal cells in the cortex. It is used to identify inadequate blood flow to the cerebral cortex, causing a surgically induced or anesthesia induced reduction in blood flow. Then uh, reduction of cerebral metabolism to predict neurological outcome after any brain insult and gauge the depth of hypnotic state of the patient. So the waves designated on EEG are alpha 8 to 13, beta 13 to 60, delta 1 to 5, and theta is 4 to 8. So as you can see, beta wave, alpha, theta, and delta. Anesthetics cause changes in cortical neuronal activity resulting in changes in brain electrical activity. This is reflected by EEG. So deepening of anesthesia, theta or delta may be promoted. Further depending, so anesthetics cause a change in the cortical neuronal activity, which results in changes in the brain electrical activity, which is seen on the EEG. So during induction, there will be increase in beta activity. This is important. So during induction, there is increase in the beta activity, deepening of anesthesia, the theta or delta prominence, and further deepening there will be burst suppression. So as the activity is during induction, there will be increased beta activity. As the plane of anesthesia is deepened, there will be theta or delta prominence, and further deepening burst suppression. The effect of noxious stimulus on EEG. Desynchronization will appear of fast rhythms, appearance of 6 to 10 Hz spindles, and burst of 1 to 3 Hz slow waves. So anesthetic drugs result in low frequency and EEG and burst suppression at high concentrations. Now what is these burst suppressions? So flat EEG with bursts of high amplitude, low frequency signal. So these are high amplitude but low frequency signal, sorry. As the depth is increased, interval between bursts is increased with proportionally longer periods of flat EEG. So flat EEG with bursts of a high amplitude and a low frequency signals. Changes seen with most inhalation agents are identical. That is, there is a decrease in frequency and amplitude with the appearance of burst suppressions as depth increases. Now coming to power spectral analysis, it is a computer assisted analysis that facilitates data compression for easier uh, interpretation. Okay, so results are compared to conventional EEG. Um, so results are compared to conventional EEG. So it facilitates data compression for easier interpretation. EEG signals can be broken down into a series of components. Sine waves typically 1 second long with frequencies ranging from 0 to 30 Hz. The power spectral analysis presents each of the sine wave components as function of frequency. So it produces so median power frequency, the point at which 50% of the power exists above or below its value, derived from EEG, is so spectral. So median power frequency, point at which 50% of the power exists above or below its value, is derived from EEG. Spectral edge frequency, below the frequency below which the power contains 95% of total EEG, and MPF and SEF is basically SEF is so median power frequency and SEF are used to measure depth of anesthesia. So the spectral edge frequency is SEF, frequency below which power spectrum contains 95% of total EEG. MPF is 4.98 Hz and predicts loss of consciousness. So median power frequency less than 4.8 Hz predicts loss of consciousness. Power spectral analysis is one of the most accurate tests that reflects patient's level of consciousness. So this is important. One of the most accurate tests that reflects patient's level of consciousness. So bispectral analysis, it is the most recent method of EEG analysis. It was developed by Aspect Medical System. It is weighed average of 4. It is weight average of 4 subparameters. So the 4 parameters what it comprises of are power, frequency, burst suppression, and BIS analysis that analyzes the phase and frequency among these components. So power, frequency, burst suppression, and BIS analysis. So it measures the effects of hypnosis on EEG. So it is a computed real time using a combination of three analysis. So it is computer generated real time. So it measures the effects of hypnosis on EEG, and it is computer real time using a combination of three analysis techniques: power spectral analysis, bispectral analysis, and time-based analysis for suppression by near suppression to look for key EEG features, right? So basically it measures four subparameters, that is power, frequency, burst suppression, and BIS analysis. Then it is computed real time using a combination of three analysis techniques, that is your power spectral analysis, bispectral analysis, and time based analysis. So power spectral, bispectral, and time based analysis. It is a numerical index ranging from 100, which indicates awake, to 0, that is no detectable EEG activity. So 100 is awake, to 0 to no detectable. So basically it measures, as you can see here, it is an average of four parameters like power, frequency, BIS, and burst suppression. It measures in real time using three analysis techniques: your power spectral, your bispectral, and your time-based analysis. The numerical index ranges from 100, that is in an awake patient, to 0, that is in no detectable EEG activity, right? The BIS correlates with the level of responsiveness and provides an excellent prediction of the level of consciousness with propofol, midazolam, and isoflurane anesthesia. So the bispectral index itself is a complete mathematical algorithm that allows a computer-based design to it is a complex mathematical logarithm that allows a computer inside the BIS monitor to analyze data from patients' EEG during surgery. The BIS correlates with level of responsiveness and provides an excellent prediction of the level of consciousness with propofol, midazolam, and isoflurane. Basically, you need to remember that 0 and 100. So 0 is when the patient is fully under no detectable EEG activity, and 100 is when the patient is awake. And uh, so multiple clinically relevant measures like movements, hemodynamics, drugs, concentrations, consciousness, recall are considered along with a counter current EEG. So So measures like movements, hemodynamics, drug concentrations, consciousness, recall are considered along with the EEG data. Now, advanced statistical analysis is used to correlate components of the multiple EEG signal processing approaches with the clinical data that is used to create the BIS index. The BIS index measures the hypnotic components of anesthesia and is insensitive to the analgesic components. So it is not sensitive to the analgesic components, it only responds to the hypnotic components of anesthesia. Sorry. This is a useful monitor to adjust anesthetic dosages and decrease frequency of hemodynamic disturbances. Uh, This leads to improved recovery. So it is a useful monitor because you can adjust the with BIS, the anesthetic doses can be increased or decreased, and this helps in improvement of recovery. So basically it is a bispectral index, which bispectral index, so it is made up of power, frequency, burst suppression and BIS analysis. It is a combination of three analysis technique, that is bispectral, power spectral analysis and the time based analysis. The BEE system, the BIS system, is integrated into patient monitoring devices. So it is already in the patient monitoring device. It displays both the raw data from the EEG and a single number between 100 and 0 that represents the patient's degree of sedation. So it just indicates a raw data from the EEG and a single number between 100 and 0 that indicates a patient's degree of sedation. So the target, this is another thing, 100 indicates awake and 0 is sedated. The target number for most anesthetized patients is between 40 and 60. So for BIS, the target number for most anesthetized patients is between 40 to 60. That means the patient is anesthetized. So as you can see, the BIS monitor, it's a neurophysiological monitoring device which continually analyzes the patient's EEG during anesthesia. So it works by placing BIS sensor on the patient's forehead. So this is the BIS sensor. To obtain information from electrical brain activity, and as you can see, a number is displayed here along with EEG. So BIS evidence-based assessment. So BIS 100 means the patient is awake. 80, so basically 60 to 40 is optimal depth of unconsciousness. Increasing, if BIS is 80, it can indicate there's an increasing risk of awareness. And below 45, the deep anesthesia effect side, the longer recovery and side effects, right? So overdosing is and deep anesthesia and longer recovery. So with 80 there is increased risk of awareness, and below 40 there is greater depth of anesthesia. So one is underdosing, one is overdosing, and one is of course optimal. So fivefold decrease in risk, awareness with recall, decrease in drug use and better emergence and PONV, that is the optimal depth of unconsciousness. And overdosing, so there's a fivefold increase in awareness with recall, because I already so then an association with long-term outcomes, mechanism, casualty. So 100 to 0. So interpretation, it is measured as a numerical value of 0 to 100. 0 is isoelectric EEG or cortical silence, that is a very deep plane of anesthesia, and 100 is awake. After administration of hypnotic drugs, BIS index decrease from 100 as patient's consciousness undergoes series of transitions. So at BIS 70 to 80 there is loss of consciousness. At BIS of 60 there is a probability of consciousness is low. At risk of 40 deep BIS of 40 deep hypnosis. At BIS of 40 to 60 reflects adequate hypnotic effect. So 40 to 60 reflects adequate hypnotic effect. This value should be correlated to individual clinical state to adjust interpatient variability, right? So it should be correlated to the clinical state of the patient to adjust the interpatient variability, right? So 40 to 60 reflects adequate hypnotic effect for GA with the rapid recovery of consciousness. Less than 40 is very deep hypnosis as it is moving towards 1. 70 to 80 is loss of consciousness. So at 70 to 80 to 70, basically consciousness is lost. At 60, probability of consciousness is low. 40 to 60 reflects adequate hypnotic effect with rapid recovery to consciousness. So clinical uses primarily measures effect of hypnotics on EEG. So basically it measures sedation, so the effect of hypnotics on EEG. It regulates the anesthetic drug use and prevents awareness. So it regulates the use of too much anesthetics and too little anesthetics to prevent awareness. It prevents awareness and decreases the incidence of post-operative nausea effects. So to reduce the length of stay, so basically to reduce the length of stay in the hospital, hence reduce complications like post-operative nausea, prevent awareness, that is the post-operative, then to prevent awareness during surgery and regulate the use of anesthetic drugs. So whenever there's hypertension, tachycardia, movement to any autonomic response like lacrimation, salivation, the patient is light. A high value indicates assessed level of surgical stimulation and confirm delivery of hypnotics, analgesics. Consider hypnotic or analgesic, increasing the dose. Consider antihypertensive. If this is in the desired range of 45 to 60, consider increasing analgesic dose. Consider antihypertensives. Low value, consider antihypertensives and assess level of surgical stimulation. Stable hemodynamics, no responses. The clinical profile is adequate. High value indicates consider increasing hypnotic and analgesic dose. Desired range is 45 to 60, observe. Low value, decrease the hypnotic and analgesic dose. So guys, that's about it for today. So the limitations of BIS are, the BIS values are affected by the choice of anesthetic agent. So basically the choice of anesthetic agent will interfere with it. The BIS monitor appears unable to accurately track changes in consciousness produced by certain anesthetics, specifically ketamine and nitrous oxide. So the BIS values differ with the choice of anesthesia. It cannot measure accurately hypnosis produced by ketamine and nitrous oxide. So the changes in the BIS algorithm resulting from updating and refinement of the producer database makes it difficult to compare results obtained by different investigators. So BIS values are difficult to correlate with other measurements of anesthesia depth, like serum concentrations of anesthesia agents. Such you cannot compare it to other parameters, and standard BIS scores are not useful in monitoring special patient populations, especially the critically ill and unstable body temperatures and patients with dementia. So guys, that's about it. We'll complete this class tomorrow. Do use my code to subscribe. I will go through this tomorrow again. Use my code to subscribe and get a 10% off discount on your subscriptions. Thank you guys. Have a good evening.